Spectacular, right on the money, so interesting. I'm so glad to hear that we got the patient not only in terms of context here, but you really gave us some really great texture about it. And so to this panel, you guys have been wonderful, and now the fun really begins. I want to thank the staff for putting this panel together. As you know, I don't do anything. I'm just up here, and they did it all. So you guys get the credit. But now we'll take questions from the committee. George?
Thanks. Great panel. Great way to start our second day. Jerry, I wonder if you could speak. So the National Center was not created specifically to promote nursing or nursing careers. Could you talk a little bit more about, from your perspective, what the center and more broadly the focus on interprofessional and education and collaborative practice means to nursing, and why is this a good thing for nursing? And then reflect as a faculty member in a nursing school, what have been the implications for approaches to education?
Okay, two questions. One is, what are the implications of the National Center given its focus on teamwork for nursing and then for faculty in nursing as well? Okay, I'd go back to what Julie introduced, which is the focus right now is looking at what the team produces for achieving quality, affordability, and a better patient experience. We all know that nursing contributes to that. And I think what the National Center does is it brings nursing as well as other professions into fine relief, because I think we all know that teams are more than their individual parts. That said, you have to understand the individual parts. And that's what the National Center is helping us to do with a variety of projects and evaluation, is what are the contributions to patient outcomes? Who is contributing? How much? What's the right service mix? And how does that get reflected in quality outcomes? For nursing, that is absolutely essential. We, as I've said, have really focused on advanced practice nurses. The reality is that nurses are the bedrock of many of the elements of primary care, care coordination, med-rec, education and counseling, and it may be advanced practice nurses, but it's also registered nurses who are virtually invisible. And so that the National Center in these evaluations and the projects and the resources is bringing that to the fore. Many of the projects are nurse-led, including the ones that I lead. Briefly, the implications for nursing education are very significant. I speak nationally on care coordination and team-based practices, and when I talk to faculty about educating for care coordination, many faculty say it's nowhere on the radar screen. And why is that? Because it's not on Nexus, not on NCLEX. And we have got to start looking at what the needs of the patient, what the delivery models are, and educating to it. And I think that the focus on teamwork is not only benefiting patients, but it's also benefiting all the disciplines that make a part of it, including nurses, but not limited to nurses.
This has really been powerful. One of our tasks, so let me be clear, one of our tasks is to not touch the recommendations from the 2010 report. One of our next tasks is to help frame how has the context changed, what are the important cultural changes that have occurred with the context change, and what recommendations can we offer for going forward? And your presentations were all laced with that, and Scott, yours too, since you're not in the room. My question is one, what else should we offer in terms of recommendations? I heard 3 from you just now, Jerry. What other recommendations should we offer about how to move these previous recommendations forward in a new context to develop a new culture? And next is, and the other thing is a plea, would you please follow up with other ideas or data or outcomes from your work to offer us to put into the report?
I think, yeah, I think that there is plenty out there for us to draw from and to make the recommendations. And in the recommendations that I listed, which, you know, align right down the line here of what it is that we're looking at. If in fact we are going to change the culture of practice, we have to change training and the culture of practice. We need to ensure, and that is not just change nurse education. We are speaking about nursing specifically here, but George, how long have we been talking about team-based care? That's medical education, that's social work, that's pharmacy, that's a whole variety of what we need to do. So we have to flip the pedagogy, and we have to make sure that we have competent people in the classroom that understand team-based practice. So you're looking at faculty development. We are looking at changing the curricula so that it supports team-based practice. You have to change the accrediting so that that's a part of it. NCLEX's probably a little slower, but nonetheless, all of the signals have to be there. We have to change the payment system to create incentives. They've done that internationally in other countries where they have incentivized practices to hire different care workers. As a part of the training and a part of the practice, we have to expand the pool of people that are brought into the team to deliver care. When you pay under a bundled payment, it shouldn't matter if it's an addiction treatment counselor who is doing the counseling in substance abuse or it's a psychiatrist. If they are both competent to do that, and in fact you probably get better results from the ATC, then that's where we ought to go. But to say that we artificially do not pay for a particular individual no longer makes any sense. So there's going to be some turf battling on how you license and all of that. If in fact all of that is to maintain quality, then quality is where that needs to be driven. The metrics can come around that. Things that are being done at the center, I'm proud to say I was at HRSA and pushed hard to get that funded, get the center going so that that could become a convening source of that information. But we have to task ourselves to no longer be content to have 50% of people walking in and not having a primary care provider. If we're that short on primary care, the probability we're going to produce enough doctors and nurses to do that is as close to zero as I can say as a researcher. So we got to look at primary care services, not primary care providers, and realign those.
So one thing that I would encourage you all not to lose sight of is where healthcare is going in the future. Telehealth has been sleepily crawling along and is starting a very exponential rise. And I think this is a very challenging area because on one hand, I would suspect we all get a little bit nervous about telehealth where somebody can fill out a form electronically, hit send and get a prescription. On the other hand, I think I would recommend that this group follow the legislation very carefully because there are some regulations being promoted that are geared to only let physicians do the telehealth, or the physician had to have seen the patient in advance before telehealth services can be delivered. So while I 100% support team-based care, I guess I'm a little bit more, I think the world of virtual team-based care really needs to be considered. And you know, patients coming to Minute Clinic are speaking with their feet that they want convenient health care. So I would just recommend that that's an important component of where you're looking in the future.
And not incompatible with teams.
Absolutely not.
Jerry, you want to jump in?
Sure. I'd like to hit on what Nancy and Julie were just saying and extend it a little further. One is certainly payment. And this is consistent with a policy brief that is soon to be published by the American Nurses Association and the American Academy of Nursing on priorities for care coordination. One is competency-based payment, so that individuals who demonstrate competency in whatever nursing or team-based skill, like care coordination, are paid commensurately for it. I would like to really emphasize measurement. Measurement in so many of the domains we're talking about are really very traditional, and they focus in on physician as primary care provider and physician specialist relationships, and do not include other team members, including community workers. And we really do need to bring in the full continuum of services into that mindset. And even with the newly developed measures that are coming out right now, and considerable money is going into them, they are very traditional. My recommendation is to really look at where we need to have measures down the road.
Diane, did you want to get in? Is that,
I do.
you got it now?
I got it. Okay, great. I want to follow up about the virtual piece. We are so physically bound, whether it's in education or it's in healthcare, that we don't think of the other possibilities.
Exactly.
And the problem is the patients and their families do. I cannot tell you how many people are out there with their own digital tools trying to figure out how to manage their health care. They need better advice about how to do that. We don't want them going and buying snake oil on the web. So we need to be a real part of that. We need to use it in education. I am so tired of people saying, we're not on the same academic calendar, so we can't get the doctors and the nurses and the pharmacists all to have classes together. Baloney. Virtually, we can do it. Get them together. Get them to start practicing. We're so content driven that we stay so focused. And some of that comes from our NCLEX exams, our professional organizations that say, oh, we must cover this much content if you're a family nurse practitioner. And what happens is the curriculum becomes that we don't really get them prepared to utilize the tools that they need to understand and utilize data from all these different sources to really provide the care we need to figure out and really support the triple aim. And we've just got to stop the physicality thinking. And as Julie said, we need to flip it around, the healthcare system as well as the educational system.
So I don't want to totally pile on, but let me build on this virtual, because I was having a real hard time listening to this discussion. And I don't want to be negative. First of all, I'm a big, big supporter of minute clinics. And Scott, you're still on. Is yours a nurse-only clinic, or is it a truly integrated nurse and physician group? I was having trouble understanding that.
No problem, sir. I'm actually solo practice. When I first started in 2012, I had a collaborating physician. One of my friends from a local medical school, I actually taught for a university. I had a medical school nursing program, PT, OT. We did a lot of different things back and forth, and he was my collaborating for the first 2,000 hours, and now I'm actually independent, so it's just me, and I do have one other per diem nurse practitioner.
All right, well.
Not have any oversight.
Okay, so here was my bit of a disconnect. I'm hearing all this discussion, and I'm all supportive of the words, interpersonal, collaborative. I mean, it just all sounds good, but I'm an economist, and we don't believe any of this stuff until it's proven. So, and then Nancy brought up the word virtual, and then Diane just made it. So, I mean, as I said, I'm a big fan. I know I've taken people from all of the other countries to the Minute Clinic. But it's a nurse-specific delivery system. I would not call it an interpersonal delivery system until you mention virtual. And now we're talking about a different way. It's not necessary, and so I want to pile on this thing. Because in a way, the big criticism of the Minute Clinics is that it's not interpersonal. There are not physicians there. It's not a team in that respect. I'd love to see some discussion about true teams. All this other talk, you know, is not around teams, but once you bring in the virtual aspect and you then become a team, as you pointed out, you link up. You never stop, whether it's through the information system or through the fact. You do not think of yourself as the be-all and end-all of the delivery system. And as Diane pointed out, so what I'm looking for and what I don't see a lot of, I'm sorry, words notwithstanding, are true interpersonal. And that's what Jerry's talking. I love, you know, we need more models of that. I see a lot of old models around the country where there are teams, but who's running them? The physicians. And yeah, they got nurses and they will have nurse practitioners and they will have, but their teams run in the old way. What I'm looking for the future is what you're talking about, Jerry, which are true teams where occasionally, and more than occasionally, the teams which have physicians in them are run by nurses. And I would welcome those examples, if anybody knows true interpersonal, they're really personal because they're interprofessional in the sense that we have these true teams that are not always run by the physicians.
I think both Jerry and Julie can give you examples.
That'll be great.
I'd like to respond to that if I could. We have a number of large clinics, large groups, provider networks here in Southern Nevada, and I have a number of patients that even though they have private insurance, still come to our clinic, basically lay out all their lab work, all their tests, and go, I get about 2 minutes with my provider. Could you go through and explain this to me as to what's happening? I think the team idea is great. I really appreciate that idea. I think it is the way of the future, and I think it's the way we need to go. But we need to dial that down a little bit further and remember this is about communication with the patient. However that takes place, the best is where this really is going to be. The virtual or telehealth part for Nevada will be outstanding due to the rural areas that we have. Urban areas, it's not as big of a deal, but in the rural, the telehealth is really going to be the way to go on this.
Okay.
Just a few examples of exemplars. One is to take a look at the Primary Care Consortium, who has identified exemplars of effective teamwork, what's called high-value teamwork, that has shown a link to outcomes. And those are both academic clinical practices as well as community health centers. There are a lot of emergent FQHCs that have novel models. Just to give you an example, we're working with several in Arizona that do one-stop shopping where when they've got high-risk vulnerable patients, they have a system that that the patient and family can see multiple providers in a very short period of time, and they're tracking outcomes. And that's some of the projects that are being done by the National Center.
There's a 20-year history of teams that have come together. A lot of them because practices, and I'm talking specifically around primary care, practices often were housed and started by physicians. But the integration of other team members has in fact changed that entire dynamic, where in fact, once that leadership is shared, and the characteristics of how that works, you do see different dynamic teams. You got Margaret right here, who talked about, I'm sure yesterday about her, clinics in Connecticut, where bringing people in federally qualified health centers, in urban centers, but also in rural areas, where more members are being brought in because the payment system is now saying, I'm now accountable for the outcomes beyond the door of the clinic. I'm now accountable for them maintaining blood pressure control, recognizing pretty soon that nurses and others have, as a part of their wheelhouse, the skills to be able to do that. And that becomes the overlapping critical skill. So there's plenty of...
Julie, let me first of all, be very supportive of that. But let me tell you what I was really aiming at. So, I'm really also pushing hard to expand scope of practice. And I'd love to see us do it in Massachusetts. But here's the issue. when you're in these bigger groups and having, particularly for patients with chronic conditions, having them see a nurse practitioner or another professional isn't the issue. It's still wrapped around a team, which is often the center of that team tends to be the physician. And in this new world, what I'm looking for, since I believe in it, where the models really, not only are they bigger teams, which you've been arguing and I've been arguing for, but often they are actually run by, and the leader is the more advanced professional, which is the nurse. In other words, I'm looking for the next generation of those teams. I'm all for the teams.
Don't forget that the patient probably should be the center of the team.
Yeah.
And, and where we're going with these millennials, and as we look to the future, and even, AARP members, they want to be active participants. It should be around the patient being at the center. That patient should be the team leader and make sure that that team is there to support them. I don't know how you charge for that and how we pay for that, but to me.
The patient charges the doctor. I like that. Nancy?
So can I paint a little bit of a vision of Minute Clinic in the future? So we have 1,000 clinics. We're going to be 1,500. 60% of U.S. citizens will be within 10 miles of a Minute Clinic. We have 60 health system affiliates, such as the Cleveland Clinic, Emory, all over the country. If a patient comes to see a Minute Clinic here in Washington, their note goes to their physician. And now with Epic, it's almost as if we have the same medical record. So you can envision we are working with telehealth vendors to set up a telehealth platform. So you can envision a patient coming to Minute Clinic without a PCP. We diagnose the blood pressure, but connect with a physician who backs us up and potentially provides the next level of care, but our center can become the medical home for that patient. We have a Cleveland Clinic patient who has surgery at Cleveland Clinic, goes back to Arizona or wherever, has their post-op visit at Minute Clinic. We have the telehealth connection back to Cleveland Clinic to hook up the doc. So we are laying the foundation for actually a national platform of integrated interprofessional health, and leave it up to the patient who is their primary. As physicians, as the nurse practitioners, we want them always to have a physician to consult with if there's questions. But with this integration, we could do the model whichever way the patient prefers.
But I would also say then, if in fact the patient is driving it, and I would probably push back a little bit about who needs to be at the center, whether it's the characteristic care that changes. Yeah, but we do have them that have been emerging, but just as you would want every nurse practitioner to be able to have a physician to consult with, I want every physician to have a nurse practitioner to be able to consult with, and the social worker to be able to consult with. To stop thinking about these as linear and the trade-off. When the patient is driving that and their voice is really represented, you're going to know who's going to be around there. We don't have that yet in place because we have state academic settings, and even the word professional that we use in interprofessional can be exclusionary, because if you didn't go to a formalized program, the care that you're being given is somehow less. That in fact what we need is, in order to be able to, and you could do that in creative ways. There was an article on a practice in which they identified those super utilizers, those high flyers, so the Jeff Brenner types, and cordoned those off, the top 5% of the users of the practice, and built teams of nurse practitioners and pharmacists. And that was their practice. And they took those on and were able to significantly improve their quality of life, quality of healthcare, and healthcare spending by using that talent base. That when you bring them together, that's going to organically work. But we're still thinking about we're paying piecemeal, and we talk pay the team, but that's not really what we're doing yet. And that's what, if you want to move forward, how does one do that?
Okay, we're going to have to move on a little bit to other questions because I'll get killed when we have the break because these are team members. So Ed, fire.
Thank you, thank you. I want to follow up with Nancy. First, I want to compliment CVS for the innovation and really appreciate the linkages that you are developing with health systems. The question about the hiring or the adequacy of preparation. You know, one of the recommendations of the committee has been to encourage residency training. And so do you favor, or do you take new graduates? What are your thoughts about the adequacy of preparation for an NP working in a minute clinic? And particularly since there are not necessarily other professionals in the facility.
I think that's a fabulous question because it is something that we are challenged with. About 40% of our hires are new graduates. And I definitely, this is my personal bias, that the new graduates are challenged. They don't have as much practical experience. You know, I just recently did a little research on France, and our nurse practitioners have about as much education as the general practitioner in France, but the French physicians, GPs, have a year of residency, and I think that is one of the opportunities that we really have. So what we do is we have our own residency program, which is about a 6-month program. We do a buddy system for a number of months. We have a preceptor that is connected with the new graduate who is available, reviews charts, does a lot of hand-holding initially. So I do think I'm biased. I would advocate more hands-on residency type experience for the new graduate nurse practitioners.
Great, thank you.
All this talk about teamwork, we all walk in with visions of the nature of the team and how it's organized, and the nature of leadership in teams varies depending upon the game you're playing. So it looks very different in football with the quarterback at the center than it does on a basketball field or a soccer field where the leadership keeps moving around. And I think Julie's discussion and vision of a team looks a lot more like the folks on the basketball team with different skills passing the ball around as appropriate. But leadership also varies in that way. And the IOM report emphasized leadership, nurses playing leadership roles more actively and being prepared to play those roles in the education system. And I view leadership not as a position in an organization, but a function that can be played at any level. So the frontline staff also has leadership responsibilities. You've described systems where you're experimenting and exploring different ways of organizing care, a dynamic system where it's evolving. And I'm wondering, what roles have the nurses in your organization at all levels played in leadership in the design and redesign of the systems that you're dealing with? That's question one. Question two is, how well prepared have they been to play those roles? And what leadership competencies or skills have been most needed and most missing? And then for the educators on the panel, question 4 is, how are you changing your curriculum to prepare your nurses to have those competencies to play those roles?
So I'll present the practical perspective, and then you guys can help fix it. So we have 2,800 nurse practitioners. 8 clinics roll up to a clinic practice manager, who rolls up to a state manager, who rolls up to an area director, who rolls up to the chief nurse. They're all nurse practitioners. We have a number of committees, leadership committees. One of our biggest challenges is the nurse practitioner leader is typically very good at HR issues and not good at conflict. not good at leading, being a visionary, and really not good at business. So I would strongly advocate that curriculums really be thought of to help put nurses in leadership, train them a little bit more around leadership, because it is an area that we have definitely seen lacking. I'll admit it, the same for physicians.
From the academic side, a lot going on in that area, and let me just give you some examples of how in my institution at Arizona State, we are really working to influence that. One is the clinical partnerships, so that we are much more active in bridging between the educational environment and the clinical environment, and really shaping projects in terms of how nurses and other team members shape care for high-risk patients, readmissions, and all of that. So we're out in the clinical areas, and increasingly we're getting asked to consult on teamwork skills and going out and shaping that. And I think, like Nancy was saying, where we see the problems are certainly in conflict management, but even in more simple things like roles. Many team members have absolutely no idea what other team members do. And social work is a great case in point. That many people have no idea what social workers do. So educating about that. Our curriculum is dramatically changing. We're implementing a new curriculum in 2016 that is really looking at systems and leadership. At the undergrad level, we already have it at the master's and doctoral level.
Yeah, I think if you're looking for leadership as a function, and that's what needs to happen, and if the appropriate end of that is a system in which its working parts are working the most efficiently to meet population health needs, or triple aim, then what does it take to get there? And to have clinical voices who also are schooled in systems change, which you can get both through your educational approaches, that is, in a collaborative way, but also more specifically to look at, just like you're looking at 5 years, what's happened since the future of nursing, so if we're looking at that, it's, okay, what does 2.0 look like? So if we've been through these 5 years at 1.0, what would we do different in 2.0? And you would want to not only build up the cadre of nursing leadership, and that is both positional as well as functional in both, but also to using the clinical voices that you have to drive a better system, and then the pieces that come around that to appropriately finance it, to be able to argue for more efficient payment systems and an evaluation that feeds both time real and over time to be able to address that. So I think when you bring those pieces together, both in nursing education, but overall in education, physicians, but thinking about it both positionally, and we haven't, because the push has been more around producing people at the master's level as clinicians, we've not seen that growth on the administrative side that we probably have needed. So there may be actually a dearth of the number of people, but I would also think about that functionally as well as positionally.
Another question.
Thank you. Thank you for your great presentations. And thinking of our nation's changing demographics and with these new team-based models, how are you addressing any cultural or language barriers and preparing your teams to help meet the needs of all patients?
So critically on that front, if you in fact do not have the broadest voice in the clinician team that is also able to listen to the patient and the family, you will never be able to address population health and cultural needs. So they really do go hand in hand. We've just got funded to do a project that is looking at how can we put our students into underserved communities and looking for preceptors there to precept their clinical experiences, reaching into communities and figuring out what are their training needs so that we can both expose students to that to increase the likelihood that they will practice in those communities, but also seeing how teams of care are organized in settings outside of academic practices, which look wholly different than what a lot of care delivery looks like out there. So by broadening the base of clinicians and health workers, it's not just the physician and nurse, it is the home health aide, the community health worker, the promotora. Who do you have in the community that really understands that and really provides the cultural competence to your practice?
Donna? Oops, did you want to get it?
One thing that really fascinates me, and this came up, we're looking now in Arizona at integrated behavioral health, and there's a lot of issues coming on in bringing medical providers with the behavioral health providers. And one of the questions that came up was, how do you assist people from multiple cultures to be active members and leaders of the team? And so it's really caused a lot of thoughtful conversation about the diversity of our population and how do you bring them into teamwork, and not assuming that every person will relate to the team. You know, as Diane was saying, it's the centerpiece, but it's something we really need to be looking at.
Donna?
So one thing for Diane, and I'm going to follow up on the cultural competency issues for a minute. A lot of current social media, patient education tools, digital tools, with the notable exception of a couple of companies that I have seen, almost completely exclude people with low health literacy and people who speak languages other than English. And we did a review for this for ARC with APT, and the promise of the health IT and the information age, really the digital divide it may not be real in terms of people's access to devices, but it is very real in terms of access to web-based information or online tools. And I guess what I'm wondering is do you see a time where for some of those populations, the telehealth and the virtual visit from a human with whom you can interact is going to trump the information that's being provided in print? What are you seeing out there that's exciting in that world, and what's the role of the nurse in promoting that?
I think there's been quite a bit of research now to really look at those kinds of disparities and to begin to look at what are the tools that people have most access to, and then how do we really create information that's usable for them. So I've seen some studies that use a lot of different things like emoticons and different things that will give you feedback to the person who maybe doesn't have the health literacy. So Sue Bakken, who I believe is going to be an IOM fellow, or that's right, this year, she's done research in New York where they have really looked at what's the best way to communicate with a patient so that they have symbols and they have icons and they use pictures to show them about where their blood pressure is. And their dashboard is different than a dashboard, and they've really tried to find all the useful information that they can provide to them in different ways to really facilitate their health literacy. So I think that's kind of the start of where we need to go to use different kinds of media.
So now I'm going to be a little provocative, because we've seen the data on the education of nurses who are Hispanic. We have seen growth, but we've also seen the associate degree nurse growing, in some cases, the rates growing more than BSN in the Hispanic nurse population. We see very few Hispanic nurses in the DNP or PhD realm, and Hispanics are just the tip of the iceberg in terms of the language spoken here in the US now. Nancy, do you have bilingual nurse practitioners? Are we equipping, hiring, educating, Or are we going to trust all the electronic stuff to take care of this problem for us?
No, I think you bring up a very, very important point. We have a concept, we call it the right provider in the chair. So I look at this issue as more than being bilingual. I look at this as much more as being culturally competent. So about 30% of our practitioners are diverse and also speak more than one language, and we obviously try to make sure that in our different communities, like in California, it's Vietnamese, and in Florida, it's Hispanic. But one of the things we've noticed is that, okay, we can take the first step by matching the language, but it's really after we've gotten a clinic going to understand whether it's a right cultural fit. And we will move our nurse practitioners around to get that right cultural fit. And so I think you're bringing up a really important point that we need to make sure folks are educated, but there is the cultural competence that is much, much more profound, I think, than just the language.
Absolutely. Do you want to jump in, Diane? Then we have one more question, then we're out of time. I'm going to get hoisted on my own petard here.
That person should also be on the team. I can reflect back 30 years ago when I worked in Boston, and we had joint practice, and our junior and senior residents were paired up with first and second year practitioners, and the team met, and we had a medical anthropologist with us because we were at Boston City Hospital, which was really diverse. And so the medical anthropologist was part of the team. And when we had team meetings so that you determine your practice for that week and who you were seeing, the medical anthropologist was there to help you frame things and help you really work with diverse cultures. And we've sort of lost that piece. And we talk a lot about that cultural competence, but we really haven't brought them in as active team members. And I think that's where, like, Sue Bakken's work has pulled in all these people to kind of bring that forward to really look at a new care model.
Last question for
Yes.
we get in trouble.
Thank you. Nancy, having 1,000 clinics across the country puts you in a really, I think, wonderful position to comment on the issue of scope of practice. That clearly was one of the key recommendations of the committee. Do you see, how do you use your NPs differently in different states because of the scope of practice restrictions? And is there one or two pieces of scope of practice that you think would be most important to enable you to provide better services across the country?
So state regulations are really a big challenge for us, whether it is scope of practice or how a consulting physician needs to provide supervision or just be available. And I think it does make certain states much more costly for us to provide the access, and certain states we don't grow as much, even though there is the demand, because it is so expensive for us. Specifically around scope of practice, I think the biggest issue is this tension between the physician community and the nurse practitioner community around chronic care support and management. And as a physician, I definitely believe that there should be team-based care and there should be collaborating physicians to support. But I think one of the biggest gaps we have is the fact that certain scope of practice issues make it very challenging for a nurse practitioner to take care of a hypertensive, a diabetic, and be a center point for that. The nice thing is Massachusetts has expanded their rules. Kentucky is still a state that's very closed. Minnesota has certain rules. So, I think that the scope of practice issue has much more to do with lobbying and loss of control, as opposed to the true fundamental issue where the training is there certainly to take care of the types of conditions that are being limited. Did I answer your question?
Yeah, that's good. I guess related. Our follow-up would be whether CVS in some way tracks this, or do you have information that might help us understand where
Oh, yes.
where there are regulatory barriers.
So we have a very, very active government affairs group, and we know all of the lists of barriers that we're working on, as well as we would be happy to chat offline about where some of the bigger challenges are. And some of them, I have to say, it's 100% political, where the legislation doesn't want to open a can of worms, and therefore they're not going to open a can of worms. Missouri is my least favorite state, so be happy to.
Just to mention one. On that note.
Just to mention one.
Thank you, Governor from Minnesota, who's been on the line. And with that, I think we will close the meeting, but with a great thanks to this panel. Has this been great? Thank you.